So, my name is Anna Dawn, and I'm a professor in nursing studies at Algonquin College in Ottawa, Ontario. And Lena Kirkham is also with us, and she is a student nurse and research assistant who worked on the development of this project. And maybe I'll wait just a little bit as some folks are still joining us. This presentation will be recorded and shared on the CASN YouTube for folks who aren't able to come today. So before we get started, I want to make a land acknowledgement. So we acknowledge that our work at Algonquin College has taken place on the traditional unceded, unsurrendered territory of the Anishinaabe Algonquin people. And we pay our respects and give thanks to the Anishinaabe Algonquin people and to the land for providing us a place to live and work and play. We acknowledge the harms done and that continue to be done to Algonquin and Indigenous peoples with intellectual and developmental disabilities, and hope that our work will address some of these health and service injustices through nursing education. So the main objective of today is to present evidence-informed pre-licensure nursing education priorities about nursing care of people with intellectual and developmental disabilities. And we will introduce a nurse educator toolkit at the end, but our agenda will journey through explaining why this toolkit is needed and the scoping review and Delphi study that informed the development of the toolkit. I'm going to share my email in the chat now. So if you would like to receive a free copy of the Nursing Educator Toolkit, please email me and I'd be happy to provide. Okay. So before we dig in, let's define intellectual and developmental disabilities. Developmental disability is an umbrella term for mental and physical disabilities that cause impairments in various aspects of a person's life and originate prior to 18 years of age. An intellectual disability is a type of a developmental disability characterized by intellectual impairments like learning, problem solving, judgment, academic, and those would be measured according to intellectual quotient scores below 70. The other characteristic of intellectual disabilities would be adaptive functioning impairments that impact personal independence and societal functioning. That could include conceptual impairments in language, memory, reading, social impairments like interpersonal skills and social judgment, and practical impairments like self-management across the lifespan in self-care and in instrumental activities of daily living. Together, we're going to refer to these as intellectual and developmental disabilities, and I'll use the abbreviation IDD. Some examples of diagnoses that you might be familiar with would be intellectual disability, fetal alcohol spectrum disorder, autism spectrum disorder, Down syndrome, Prader-Willi, Angelman syndrome, Fragile X, to name a few, not conclusive. Individual experiences of these disabilities range in degree of impairment and associated needs. And the prevalence, according to 2022 Stats Canada, is that 1.5% of people over the age of 15 have developmental disabilities, Although many researchers have found and estimate prevalences to be underestimated and suggest that a more accurate prevalence is around 4%. So, although Canada is not well represented within published literature about pre-licensure nursing education about people with IDD, we realize that this might not be reflective about what's actually being done and just not shared in publication. So I'd like to open up a brief discussion of how your nursing program might be including people with IDD and content about within theory lab and clinical settings. So I'll open that up for anybody that might like to share. Yes, you could use the chat or you could raise your hand.
Hi, my name is Alicia Gilchrist. I work in Nova Scotia Health with the bridging program, and I guess one of the ways that we integrate content is how we present cases and case study scenarios. So whether that's in the sim lab or whether that's like working through case studies with coursework, we will integrate kind of a structured presentation if it applies. So we've been selective sometimes about using terminologies in introductions, but we usually have some mention of ability. So if they're able-bodied and that's relevant to the skills that they're being asked of for that case, then we'll present some description to kind of include with their case study presentation of a patient.
That's fantastic. That's fantastic. And in the chat, Karen says sometimes providing increased mentorship time. Excellent. Is that in the clinical setting? Yes. Excellent. Excellent. Thanks for sharing. Does anybody else have any examples that they want to share? Go ahead, Lena.
Hi, so I can speak to as a student within the Algonquin College nursing program. We had the fortune of having Dr. Don do a presentation regarding disability theory within a nursing ethics class, which was very informative. And I enjoyed having that different perspective on this issue in this demographic.
Thanks, Lena. Anyone else have anything they would like to share? My thought, the rationale for this conversation is that as we did the scoping review, we felt that probably there was a lot more going on in Canada than what was published about. Okay. All right. Well, let's carry on then and get into our content for today. So to start our journey for today, I'd like to explain why research about pre-licensure nursing education, about people with IDD, and a toolkit are needed. So people with IDD experience higher rates of physical and mental illness compared to folks without IDD. This population also experiences poorer health outcomes. Some of these differences are related to the IDD disorder itself, but others are related to inequities in healthcare. This population also has more frequent encounters with the healthcare system and thus nurses. Some examples of Ontario research. So a large Ontario cohort study by Lin et al. Found a higher prevalence of 30-day repeat emergency department visits, 30-day repeat hospitalizations, alternate level of care days, and long-term care days experienced by folks with IDD compared to their counterparts without. And in a recent 2025 study by Salek et al. In Ontario, found that people with IDD represented 22% of alternate level of care long stay patients in psychiatric wards in Ontario. So long recognizing that people with IDD have higher needs for healthcare and often receive poorer care, the United Nations in 2006, the Convention on the Rights of People with Disabilities, called for healthcare providers to receive education about people with disabilities. Canada is a signatory member. In 2022, however, the World Health Organization Global Report on Health Equity for People with Disabilities identified long-standing inadequacy of healthcare provider education and renewed the call for disability inclusive education for all healthcare workers. Now, despite these calls and great progress in community living and deinstitutionalization, there remain significant gaps in pre-licensure nursing education globally, including gaps include nursing education resources, including text considerations, including limited IDD-focused faculty, and Canadian Nursing Association direction specific to this population, often leaving nurses feeling unprepared to care for this population. So what is written about this problem? We understood the longstanding problem of inadequate nursing education, but we wanted to know what is being done in pre-licensure nursing education around the world to include content about people with IDD. We reviewed primary studies, nursing field notes, and discussion papers to map out content, topic themes, and capture all voices on the topic. We included 135 articles, 62 being field notes and 61 primary studies, 12 discussion papers. And we identified the broad content themes listed here. So these themes identify what is often taught about people with IDD within pre-licensure nursing education programs globally, but they don't tell us if these themes are priorities. Only 4 of the articles were from Canada, locating a regional gap. And the voice of people with IDD were rarely included in the research, design, and delivery of the content. So this provided us with a justification for a Delphi study. So to address the Canadian context gap, and the missing perspective of people with IDD within nursing education literature, we decided to conduct an inclusive Delphi study. And the aim of the study was to identify priorities for pre-licensure nursing education by surveying people with IDD and nurses with experience caring for this population. The inclusive part of the Delphi study refers to inclusive health research methodology, which is aimed to meaningfully include people with IDD as research team members for research studies that will often also include people with IDD as participants. In this Delphi study, research advisors with IDD collaborated in the design of all study tools for easy read, plain language, accessible, and culturally safe design. And we can see one example here as a consent tool that was one of the many tools that were collaboratively designed. We used a Delphi technique for this study. So through Delphi, we had 3 survey rounds. We identified people with IDD with experience of being cared for by nurses, and nurses with experience caring for people with IDD to be the expert participants. In a Delphi study, participants are referred to as panelists. The benefit of Delphi is that experts share their opinions about a topic anonymously, and then in subsequent surveys, panelists are provided anonymous controlled feedback from the group response rate and key quotes to open-ended questions to consider when rewriting survey items that did not reach consensus. The anonymity promotes equal speaking positions for everyone and the opportunity for each person to influence others. The objective of this study was to determine if people with IDD and nurses collectively agreed on rating any of the presented content topics that originated from the Delphi study, and if they identified any other priorities which they would then rate. So survey 1 had 28 questions that originated from the scoping review for panelists to rate. And you can see the rating scale in the one example on the right. And they also had 6 open-ended questions to add any additional feedback about other priorities that for them to later on rate. Content analysis of the open-ended feedback generated additional questions that panelists then rated in survey 2. Questions that did not reach consensus on any Likert point returned in subsequent surveys until the 3rd and final survey. And our overall objective was not looking for anyone to necessarily or agree or not to agree, but more rather to determine, is there agreement on any of these proposed priorities on any Likert point? So it would be totally appropriate if the group had said, we don't think that any of these are priorities, or that there is general non-agreement. It was really a pulse check of what stakeholders think about these commonly taught themes. This is just for interest. This slide illustrates the flow chart of the iterative data collection and analysis Delphi process across the 3 surveys, which you could read more about if you were interested in the published study on the Delphi. So the results: 16 adults with intellectual and developmental disabilities from within an Eastern Ontario region participated. They had diverse support needs, and 16 nurses currently licensed to practice within Ontario with care experience with this population also participated, and their results were combined. So they were not separated. So to our surprise, Panelists met consensus on 34 of the 38 items, and the consensus all landed on rating these items as very important for student nurses to learn about. The item breakdown by key themes is in the right column. And in the following slides, I will present the specific topic items, but I won't read through them each. It would be quite hard to digest 34 items in a webinar, but I'll give you time to take a peek at them, and I'll elaborate a bit on the items that were generated from the open-ended questions. These items formed the Nurse Educator Toolkit, which I'll orient you to in a little bit. So we'll start with the key theme of patient-centered care. It is a very broad theme. And just a reminder again, the bolded terms are new priorities that were generated from panelists' open-ended questions. All of these identified as very important. The overarching theme in the panelist generated priorities are around promoting dignity and respect, recognition of individuality, commitment to promoting the self-determination of people with IDD to their fullest ability, and to promote student nurses to be curious and patient, and to employ a disability-centered cultural humility. So I'll give you a little bit of time to take a peek through that, but within the Nurse Educator Toolkit, there is a quick fact sheet of all of these, and then each one is broken out with mapping and resources that we'll take a peek at. I'll just give a few more seconds before we move to the next content theme topic. So the next content theme topic is communication priorities, where 6 priorities were identified. Again, we can see the respect in nursing approach and maintaining focus on seeing the individual as overarching themes. Looking at number 11, talk nicely to me, not down to me, is a subtopic theme taken directly out of the language of participant feedback. So panelists all talked about negative communication approaches that they have witnessed or experienced where nurses infantilized or patronized people with IDD, or that they perceived to be rude. And panelists requested that nurses really focus on niceness and kindness and not talking down to folks with IDD. And I'll give you a minute to take a peek through some of the other priorities presented there. The next content theme was advocacy priorities. So I'll give you a moment to take a peek through. Where some seem to overlap, there certainly is some overlap. Within the toolkit, we've provided some narrative context to help distinguish a bit and to provide some potential direction of how might we make this an actionable item within nursing education integration? The next content theme of specific diagnosis and health priorities generated 6 priorities. And number 22, do your job right, uphold nursing standards. Panelists describe people with IDD as not receiving care from nurses that reflected the general standards, and thus wanted student nurses to do their job right and to diligently uphold the standards when caring for this population. And when we get into the nursing education toolkit, when you have time to look at it, we talk a little bit about the unconscious impacts of diagnostic overshadowing that can often impact care related to this population. And I'll give you a moment to take a peek through. The next content theme are collaboration priorities, and 4 were generated from the Delphi study. Panelists emphasize the importance of student nurses learning to include family and direct support workers as part of the collaborative practice, recognizing the importance of including the people who know the person with IDD best when appropriate or when requested by the individual with IDD. Panelists also emphasize the importance of student nurses learning about IDD specific roles of interprofessionals and expanded upon awareness of traditional interprofessional nursing education to include developmental support workers, which as of right now is a big gap globally within nursing education about interprofessional collaboration. They are a group that is missed, and it's very important in terms of promoting optimal health outcomes for this population when appropriate. I'll give you a minute just to look. Okay. And our last content theme relates to decision-making priorities, although you can see some connection across some of the prior priorities that we've talked about. A new concept that's unique to people with intellectual and developmental disability. Informally supported decision making, yes, but formally in some provinces, supported decision making has come into legislation in a modified way of promoting self-determination through supported decision making. So there are some resources that will speak to that in the Nurse Educator Toolkit. It's currently not within Ontario legislation, but it could be something for us to advocate for. Okay, so to present 34 items in a lunch hour webinar, this was the best way I could think of to make it digestible, knowing that for anyone who would like, please do email me and I'll send you the toolkit that will expand upon all these with resources. But let's get to this discussion. So the implication of these findings are that there is much work to be done in all areas of nursing education, and that all of it is very important at this time. The priorities added by participants all center around promoting respect and dignity, seeing the individual, and locating practice considerations that are relevant to IDD care. Nothing without us is a key principle of the Accessible Canada Act. And this statement is an evolution from the nothing about us without us statement that originated with the disability movement. The previous statement of nothing about us without us might imply that some things aren't relevant to people with IDD. A move to nothing without us rightfully identifies that all, in this case, nursing practice and learning, is of relevance to care of people with IDD. This helps answer the question, where would we make considerations about people with IDD within pre-licensure nursing education? I would suggest everywhere. My reflections on this inclusive research work are that inclusion of people with IDD is pivotal in designing research that is both relevant to IDD-specific health issues and that includes people with IDD who have been historically and continue to be often excluded from health research. This work importantly requires researchers to honestly and continually reflect on their own unconscious biases about people with IDD that become revealed through these working experiences. And I could share more on that at a different time or if time presents at the end of this presentation. The benefit of meeting with panelists with IDD at 3 points in the Delphi survey to complete the 3 surveys provided opportunity for panelists to establish trust with me and the process, and in their self-efficacy to participate in research, and in their empowerment of sharing their voice. Many said that they had rarely been asked to share their perspective and felt very proud of their work and contribution to make a difference. From this work, we developed the Nurse Educator Toolkit, which I will show you next. The next steps for this work will be research on development and evaluation of pre-licensure nursing teaching and learning methods, addressing some of the identified priorities. We'll also be continuing to develop connections with people with IDD to partner in research, to partner in co-teaching design and delivery, and community stakeholders to expand student nurse exposure to this population. And lastly, to form IDD nursing interest groups to move forward a unified Canadian nursing recognition that competencies to care for this population are an entry to practice expectation for all nurses, and to share the approach of the Australian Nursing Association. This is every nurse's business. So I will show you the toolkit inclusive of the 34 priorities designed to guide and support nursing pre-licensure educators in including content about people with IDD. You will see that each priority has been mapped to the Cashin National Nursing Framework Essential Components for Baccalaureate Programs, the Canadian Nurses Association Code of Ethics for Nurses, the Canadian Council of Registered Nurse Regulators Entry-Level Competency, and the Canadian Council for Practical Nurse Regulators Entry-Level Competency. And each priority has also been supported with evidence-informed practice resources and research. So I will stop sharing this screen and I will bring up the toolkit to just orient you to know what you're going to expect if you want a copy, and then we can open this up for discussion or feedback. Okay. So we have a table of contents to help guide you through. Many working teams came together in the work of the scoping review, in the work of the Delphi study, and in the development of this toolkit. So their recognition is there. The background that we discussed at the beginning of the presentation is here. All the references that were used for the presentation are informed and are included at the end of this presentation if you're interested. A summary of the work that went in. We have a quick fact sheet of the list of priorities for folks to look at, and then they are further explored, below. Each one presented with a little bit of context, a mapping to each of the 4 Canadian nursing organizations, and then relevant supports and resources are provided under each. So for some contexts that are maybe a bit more relational or ethics related that were generated from participant feedback, there is a little bit of a narrative explanation. Now, these resources aren't considered to be comprehensive or the only way of interpreting these priorities, but they're to provide a starting point for faculty who are all working to your full extent and time is of the essence to give you a bit of a guide. And I'll come down to the bottom. This goes on and on. Within Ontario, we are a hub of many research groups looking at care of folks with IDD. However, the speaking position tends to be from primary care perspective, medicine, psychology, psychiatry. Many of these resources are relevant and transferable and can be used by nursing, but we need to adjust for our scope of practice and entry-level expectations. So these very important resources are presented here, but some of their components are referenced specifically with underneath some of the priorities. We also have, and they're listed under the palliative and end-of-life care, a new IDD palliative network within Ontario that is led, does have nurses as the co-chair. So I have presented a link to their website, which is being developed, but there's exciting times in IDD health. And then the resources. So it is your lunch break. I've focused your attention for about 40 minutes, so I'll stop there and open for any feedback or questions, or I'll leave that up to you folks. Go ahead, Karen.
I'm just wondering if the reason the information regarding the under 18 is limited because of the diagnosis is difficult to get. Having 2 children with learning disabilities in this form, one of the challenges I saw as a parent and as a nurse was trying to get the identification. And when it did come, the one was at 6, which is the cutoff point for one diagnosis. Yes. And the other one, girls are less likely to be diagnosed and less likely to be identified as having a learning disability or intellectual disability. And when it finally is identified, it can be so late that there are other strategies to support them going through is very difficult. So I'm just wondering if going forward, is that going to be something that we might identify earlier, and then also understand that this impacts later on when they haven't been diagnosed early?
So, yeah, the diagnosis piece of it and nurses' role in that within our scope of practice is really important. My thesis work was around understanding service navigational barriers for children with intellectual disabilities. So I completely understand where you're coming from there. It's certainly something that could be added as a consideration when we're teaching about this population, to recognize that often receiving supports and services is attached to obtaining a particular diagnosis from a particular provider at a particular time. That is not specifically recognized in this in this toolkit right now, but it's not inappropriate. And probably, next steps right now, this toolkit, the participants were over 18, and part of that was in terms of how do we navigate ethics and how do we obtain information, and for folks to have more of a lifespan to reflect on their experience with nursing encounters. But certainly that would be a relevant, the pediatric side is a gap in my research from this Delphi that could be further work. Yeah. Does anyone have any other questions or thoughts or feedback?
I'm also wondering if there's a lot of people, adults, that have never been diagnosed, that are now in their 50s and 60s, that would have been if they were in the school system today.
Yes. Could you repeat that? I was distracted by reading the chat and listening, and I missed.
I'm wondering how many adults over the age of 50 would have been diagnosed if they were in the school system today, because there's a lot that didn't finish, didn't go on, or were subject to various treatments because of the fact of the time they grew up. Where today that may not have happened. They might have been given the opportunity to see a specialist or to talk to somebody or have a nurse advocate for them, where back then, 50 years ago, that wasn't the case.
Yeah. Yeah. And back then, I'm not an expert in terms of how did people become identified, but the prevalent treatment would have been institutionalization. And we know that life expectancy in the institutions was markedly shorter than people outside of them. But still today, there's great research work in Ontario, Yona Lunsky and the CAMH group doing lots of population data that is consistent with global numbers in terms of this population having exceptionally younger, more shorter life expectancies, and some of that being part of, sometimes there's some genetic changes that contribute to that, but there's also a lot of literature to support that their healthcare access contributes to poor or inequitable care or deaths that could have been amenable to proper care. So, yeah, it's interesting for sure. Yeah. There's a question in the chat. Would you share your perspective regarding the striking a balance between including references to people with IDD in content that is already being taught, by including case studies that include people with IDD when teaching about aging, and creating more learning experience that are really centered on the unique needs of people with intellectual disabilities? So yeah, I think there is a back and forth discussion amongst IDD nursing researchers about how to integrate content. There's a strong sense that this shouldn't solely be a separate course, particularly one that is um, an elective, partly because that supports the idea that this is a special interest or this isn't a required knowledge. So I would try to straddle the suggestion that when we're thinking about diversity, equity, or inclusion and equity, and I put them in that order for a purpose, I think when we're thinking about how do we make our content more DIE, then when we're having those considerations to think about would we change like one someone here started with considering a case study where the person has an IDD, and how does that change the nursing approach and what are some considerations, and then there are some very focused specific content that might be more specified towards the unique needs of folks with IDD. So I'd say somewhere in the middle. But when we think of things even like pain, we don't know what we don't know. And a lot of scales and assessment models that have been designed that are used in the general population have not been validated or are known to not be appropriate with folks with IDD. And often folks with IDD are not included within large ECT, or sorry, within large trial studies. So it's important to know when we're applying assessment tools or screening tools to be looking in the fine print. Now we know after this discussion that it's something to look for. Is this appropriate to this population? So even when we're talking about pain, when we present a general tool, do we also present, if you're caring for folks who do not use verbal language and who have an IDD, this would be an appropriate tool. And there's an excellent researcher, Bro, from the University of Dalhousie, who has produced excellent research and pain assessment tools for this population for many years. So they do exist. It's just whether we know that we need to look for them. You're very welcome. Any other thoughts or feedback?
Hi there. If I could share, yeah. My name's Lori. I teach in BC in an LPN program, and thank you so much for this presentation. It was really insightful and I think brought to light how much we are not incorporating this particular population. And I can see some real value in even adding like the examples you provided, but I teach a professional communications class and I can just see great opportunity, especially with that subset of communication that you were talking about. And, the respondents talked about just talking nicely, not talking down, being curious. So that cultural humility piece of that, like that we could incorporate that even quite simply, yeah, through case studies and, some of these small opportunities where we have students role playing. And so I think I agree with you because there's such a wide, if we're thinking about somebody's diagnosis and we're thinking really just about the actual developmental disability, we don't need to know the explanation behind it, but just how do we approach people that might communicate or respond in ways differently than we do. And yeah, I think it's really great food for thought. Like this makes me think about how we can better approach because we focus so much on different parts of the lifespan and maybe a diagnosis, somebody with dementia, how do we approach these clients, but we should be thinking just in general if yeah, anyways, it's just opened my mind up to different ways we could make sure that we include this population. So thank you so much, this was helpful.
Thanks so much for sharing. And a piece of that too that's very exciting that came out in our scoping review that we didn't focus on too much here, but uh, folks with IDD in co-teaching roles. And there's some great evidence and some great studies out there about people with IDD being standardized patients. So really, and the what I would say from the folks that I worked with as research advisors, as well as the participants, is that for folks that want to participate, um, it's there's a what people have shared with me, a theme that I have heard is this dedication and commitment to really wanting to participate and to influence and affect change because and to have their voice heard. So there's some good literature to support that as an option. Um, and some good connections. There's some resources in the toolkit of where you might find folks who might want to be standardized patients who have IDD. So places like community living, um, people first chapters, there's all kinds of different places, and in different provinces and territories there'll also be developmental services and agencies that kind of vary in name but are kind of structured similarly. So it's that's an exciting kind of transition that I'm looking forward to myself as well in terms of the teaching learning research piece.
Thank you so much.
Thank you. Does anyone else have any questions or feedback? And again, I'm just going to put my email here in the chat thread. Hopefully I spelled it correctly. That's good. So for anyone that would like a free copy of this toolkit, please email me and I'd be just ever so happy to share it with you. Go ahead, Na.
Hi, Anna.
Hello.
Thank you very much for your dedication on this subject and the presentation. It's just for other attendants, Anna and I work in the same institution at the Algonquin College. Yes, admittedly, there's a lack of education piece regarding IDD population in our nursing program, PN and BSN programs included. Anna, you know that. So on this occasion, opportunity, I wonder that. So now we are launching our BSN standalone. You should be a voice to advocate for this education piece for our future nursing student. That number one. Number two, I think that I used to work at CHIL, and I think this is a great opportunity for pediatric nurse to be aware of in dealing with client with diagnosed with IDD. So I think CHIL is upcoming very soon, a nursing conference. So maybe it's an opportunity for you to present this presentation there too. I think it's going to be very valuable and great insight for pediatric nurse at CHIL. That is just my thought. I am teaching the interprofessional education and fourth-year BSN collaborative program right now. And truly, we did miss to include this vulnerable population in our content. For that, I do apologize. And I think, yes, this is the important point to include before these nurses graduate and exit the program and working in the workforce. So I don't know, maybe I bring this concern to the team and see how do we incorporate the knowledge about this population into the course. Not sure yet at this moment, but I will think about that more. Thank you, Anna, so much for the presentation.
Thanks so much for sharing. Thanks for your perspective. And certainly the objective is not to make anyone feel bad. This is a struggle and a bit of a gap globally. Now, the UK and the Americans are doing much better than us. So there are folks who are contributing more. But it's a place to learn. It's a place to grow from, and certainly, I think that even from our faculty conversations of what's important with nursing, I think it's a shared interest in nursing in the profession in general that we want to promote equity for all people, particularly people that are vulnerable to experience challenges in health and healthcare. So I think that ethos is an excellent place to start from. And certainly there are lots of folks that are requiring attention to improve health equity, and this is one of them. So my objective was just to give some tools for folks um, to start to think about how they might do that. But it's not a Canadian gap. It's generally in the literature shown to be a broader world gap in nursing education. So we can all pick a piece. Yeah. Any other thoughts or feedback before we end for today? We've got about 3 minutes.
And I recently did a paper, and one of the striking things I found about it, it was on dementia care and consent. And what you
Oh,
do for
yes.
what you do for the intellectual disability is very able to be transferred over to that dementia population, stroke population as well, which I found very interesting and fascinating at the same time, because it wasn't something I was thinking would happen. And when it was done, the one prof also said to me that it is an area that is also being looked at, because what you do in one area for teaching, and specifically the medical doctors and things like that, can be transferred over. And if we start younger with them understanding, then there's a
Yeah,
better chance later on that this will produce better traction in the community.
absolutely. Absolutely. Yes, we don't have to recreate the wheel. But I think some nursing publication, either through, discussion papers of what you've done, or if you're working on scholarship in these areas, looking at literature, or introducing some teaching learning research and putting it out there, also helps us as a Canadian nurse educator community to share what we're doing, so that we're not these silos that maybe are recreating each other's work, and we just don't know that other folks are doing it. So yeah, that's an interprofessional sharing, like you said, Karen, too, is definitely, building off the work is important, especially in this time that there are so many priorities. Yes, yes. Well, that looks like our time. We have 1 minute, so maybe time for one more question or feedback if anyone has any. Thanks so much for your feedback, Alicia, in the comments. Well, we are at 1 o'clock. Thank you so much for sharing your lunch hour and your feedback and contribution. Please do email, and I will be happy to share the toolkit. Thanks for Cassin for hosting this webinar and for sharing it online for folks. And for folks watching on YouTube recording, please do reach out via email if you would like a copy of the toolkit, and have a great rest of your day. Thank you. Thanks so much, Jessica. I'm going to head out from the meeting now. Thank you. That's excellent, Megan. Yes, yes. Yeah, there's lots of opportunities for sure, especially in unique community clinical placement sites. So that's lots of opportunities for us for sure. Yeah, yeah. All right. Thank you very much.